Nature of Society, Part 4, Session 6R. This week we begin a new topic, which is health. This service is the subject of much anxiety and a concern for many persons residing in both the developed and developing countries or world. The anxiety and concern is because of the inability to afford the service by the majority of persons in both worlds. In the United States in particular, the largest economy in terms of GDP, the country is struggling to find an affordable way to offer the service to all of its citizens. In the developing world, the health services are considered by and large to be wanting. For the next few sessions, we will consider a better way forward that can guarantee an affordable and acceptable service to all in both the developed and developing world. The better way forward. For any health initiative to be successful in any developing country, or for any country for that matter, the economic deficiencies of the country and its citizens must be addressed. We have seen increasingly that the health data coming out of the European and the American regions are consistently better than all other regions, and the Africa region, the poorest of the lot, has been consistently performing the worst. This then should be the focus of the UN and the WHO to bring about a wholesale economic transformation of the poorer regions if they are to see any sustainable health transformation there. We have consistently advocated in these sessions and elsewhere that site value taxation is the best and most efficient way that any economy may be transformed. We are urgently recommending the same here, and we believe that this policy and strategy is the single most vital and important policy that all countries must adopt if it is to begin to see real success in its programs. We have said before that site value taxation optimizes the employment of labor, capital, lands of value, and trade. It also ensures a level playing field and gives no one or group within a community pecuniary advantage over others. Most importantly, it makes citizens economically self-reliant and not having to depend on the state or on other benefactors for handouts. Citizens would be in a far better position to pay for medical and health needs. The next priority for developing countries is preventative health programs, and in this regard, health education is essential for dissemination throughout all areas of the community. It must become an integral aspect of the education curriculum in primary, secondary, and tertiary levels. This is with a view to changing the diet and nutrition cultural practices that are detrimental to health into more healthful practices. The use of continuous promotional public campaigns to reach all citizens about the virtues of the more healthful practices will have to be adopted, as well as legislation limiting or banning the use of unhealthful products, many imported into the community. The burgeoning cost of health is due in part to unhealthful practices that are causing the stark increases in non-communicable diseases and mental health issues. Communities must begin to give equal importance to preventative health than it would to national security, as they cannot sustain these burgeoning costs. Post-diagnosis health costs also must be looked at because many of the drugs and practices are proven to be harmful to patients in terms of side effects and drug effectiveness. Certainly, Western medical practices could become more open to that which has been practiced in the Eastern civilizations, many of which have centuries of effective results reported. Training for health professionals and other personnel should also be a priority for developing countries. There should be the thrust to provide the best professional training for all necessary medical resources, because the cost of importing trained personnel would be far greater and would still leave the country deficient in medical resources over time. An SVT environment would ensure that terms and conditions of employment of locals would be comparable to anything available in the more developed locations. The brain drain and the attraction of locals towards better working conditions abroad would be mitigated. The highest standards and practices of the medical profession must not be compromised. We now come to the important issue of the vehicles for the delivery of healthcare services, particularly in the developing world. Traditionally, health facilities have been state-owned, with privately owned facilities catering in the main to citizens who have the means to afford such services. State-owned facilities have been traditionally short on the requisite medical personnel, be they specialists or general medical doctors and nurses, or medical professionals that comprise the spectrum of service providers that would be found in any of the metropolitan hospitals in the developed world. State-run hospitals in the developing world can neither attract nor retain these personnel in the requisite numbers. Shortages of medical supplies are also a perennial problem, both in quantity and quality, as funding for these are often strained. As a result, the services provided at these facilities are not of the best, and in the case of specialist services, the recipients must be deferred to those facilities available in the metropolitan first world areas. Health budgets are constantly under pressure to cater to these special circumstances, and much less to the normal circumstances. In most instances, recipients must arrange funding for themselves if they are to avail themselves of these services, which in most instances are emergencies. The time has come to have a renewed look at how healthcare is provided for, delivered, and funded. The state-owned, state-run model has run its course in terms of adequacy, viability, efficiency, and effectiveness. Recipients, particularly in the developing world, have endured many long years of these deficiencies and would welcome a new dispensation of healthcare, one that is more efficient, affordable, reliable, and catering to any special medical need that they may have. We are talking now about privately run facilities that traditionally provide better services and supervised by the state. This represents the best option because it would bring together the level of service desired by the recipient and the affordability which the state would attempt to bring about through its health insurance schemes. The state, through suitable public-private partnerships, would establish, through hospitals, health centers, and the like, best practice facilities that would cater to the health needs of the country. They will, through the Agency of Health Service Commissions, contract these healthcare providers, which can both be local and international, vet and supervise their personnel and operations, as well as recommend payment for the services they provide. Contracts ideally would be up to 5 years duration, with the option to renew, and the important elements of the Commission's operations would be to carry out periodic audits and adjudicate on complaints made by patients and other recipients of care. The service providers are free to hire staff from any source once these personnel meet required qualifications and experience for the posting. Healthcare providers would have to have the capacity to provide those specialized services whenever they become necessary for recipients, and these should be provided locally so that the need to travel to metropolitan facilities to obtain same now becomes unnecessary. Using the tender process, they will compete with others to come up with the most competitive service offerings, both in terms of cost and quality. Cost of service would be reviewed annually along with the level of service provided. The transition to this new dispensation need not be difficult. Firstly, in an SVT environment, the labor and employment markets would become very flexible. No longer would workers be fearful of losing employment or means of living. The labor market would open considerably, and this no less in the healthcare industry. State-owned facilities could more easily dispense with their labor force, as better employment awaits them around the corner. The competition for competent staff would see to this. The state could also easily arrange to have the displaced staff considered for employment in the new public-private partnerships, they having previously met all the employment requirements. What do we think of this? Let's take the break now. In the transition phase, any new health facility would be of the public-private partnership model. There may be the need to build many of these facilities if the state-owned ones are particularly rundown and outdated. In this scenario, a fair level of decanting would be necessary. Any new or refurbished facilities would have to measure up to those facilities that are considered best in place if they are to offer best practice medical care and services. There should be no compromise where this is concerned. We now turn to how this will be paid for. There is now a raging debate in the United States in 2017 on how the healthcare system should be fashioned and paid for. The country is attempting to jettison the current Affordable Care Act in favor of something that is more affordable to the state and less rising in cost over time. Other first world countries, particularly in Europe, use the single-payer system, where the state pays for all healthcare costs and recoup these costs through taxation, or part of the cost through national health insurance schemes and the like. In the US, the real debate between the two rival parties is about whether the state should entertain the individual healthcare costs of its individual citizens or not. Why healthcare systems around the world are so challenging to administer because of affordability and rising costs upon the state is due again to the factors of production, land, labor, and capital, not optimized and out of balance. If this was the case, labor would be fully employed with real purchasing power, land values would not be so high to preclude its use for health facilities and the like, and capital would not be expensive and inflationary to cause health costs to be so high and rising over time. This is the missing element in the debate in the US, or for that matter in any country that has a national insurance scheme, or in the developing world where the full cost of healthcare is taken on by the state. Like all other expenses to the individual and the family, healthcare costs are equally applicable as are food, clothing, and shelter. Most individuals and families would not object to this cost, as to them, healthcare is a private matter that should not be subject to the intrusion of the state. If their ability to pay is greatly enhanced through an SVT regime, this would make citizens very happy, as they would now have some control over this important element in their lives as far as affordability is concerned. If all hands are fully and gainfully employed in a community, the pool of funding that would be created would be far more bountiful than if only a portion of the community is so endowed. A successful and healthy healthcare system depends on the adequate and appropriate funding for all of its various aspects. And what better way to ensure this if all its constituent contributors, taxpayers, can adequately contribute to this important endeavor? The main reason why national health insurance and social security insurance schemes all around the world are failing or are scheduled to collapse sometime in the future is because of the inability of contributors to adequately contribute and because of rising costs. The single-payer system is the best system for any country that has started a recovery process, which is certainly the case for one that would have recently adopted site value taxation. The individual citizen would be in no position to afford any costly premiums in the first instance. As the economy grows and as personal wealth also grow, as will be the case under SVT, a co-pay system would now be applicable. Government can now offload some portion of the expense on the individual whose ability to pay is now growing. This is also desirable because the citizen now has a greater vested interest in a better healthcare system, and providers would be under greater scrutiny than under the single-payer system. With the pool of funding growing, the state would be in a better position to fund all those improvements that are demanded by the WHO. Such activities as the financing of the research on local diseases, the improvement of the collection, analysis, and dissemination of all health-related data, and the ability to pay for and host those specialized medical procedures only now available in the first world countries would now be possible. Over time, the ability of the individual to pay the full premium of the insurance would materialize under SVT. The state would now free itself of this expense, but would still have the supervisory and auditing role to play in the healthcare industry. This role would not now be less important, as the management of all the elements of the healthcare industry will require close supervision, adjudication, and decision-making. In this final stage of healthcare insurance of individuals, the state would finally free itself of this obligation to provide subsidy and financial support to the community's health expense, as the pool of funding created from individual contributions in a national health insurance scheme would fund all health costs. This then is a picture of how healthcare could be provided under an SVT regime. Before we conclude, are there any questions or comments about all of this? Next week, we will continue our discussion on a new subject, health and social development. Okay. In other words, we will continue the discussion on health and social development. Before we end, I would like again to let you attendees know that On Sustainable Development is an educational offering devoted to the dissemination of its course to all of mankind and to those who have the English language as their official language in the first instance, and to all eventually all over the world. We have in fact been sending this course all over the English-speaking world with very favorable responses. To continue to make this possible, and because we do not charge a fee for this dissemination, we rely wholeheartedly on monetary donations to meet the cost of achieving these goals. If you have found these sessions useful thus far and would like others to have access to them, we would gratefully accept your donations should you be inclined to offer them. You can send donations to our PayPal account at the email address nigelgittins@gmail.com. Thank you for your kind gesture.